And the other interesting aspect is that this patient was receiving, oral anticoagulants since till yesterday. So we had to give her vitamin K and also give her this new medicine. This is the combination of all these factors which was given to her, or Optoflex. Optoflex was given intravenously 3,000 units. And this has brought her INR from 7 to 1.
Oh, great.
From morning till this afternoon. So can you see that now? Yeah. Superior.
Yeah.
Okay.
It's probably sliding along the gutters, which are created by the bulge in the intrahiatal septum.
Okay. So any more? Inferior. Inferior. Yeah. Are you okay?
I think the tent is being created at the same spot. We haven't really moved.
Put the wire on this. इसको निकाल दो. This looks okay. Okay. इसमें ये डाल दो. ये निकाल दो. Yeah, उसमें वो डाल दो. उल्टा opposite end है. डाल दो पूरा. धीमे. So the गया. गया. Is the needle inside? Yeah. नहीं निकालो नहीं. Are we good at the right position? Are we punctured? Not yet. According to fluoroscopically, it looks like we are punctured.
Yeah.
No. Not yet. How is the position now? Yeah. Inferior. Now?
बोलोगे भी तो आवाज भी जाएगी. म्यूट करके रखिए, आवाज पे जाए.
Again.
Yeah, it's slipping on the gutters, slipping on the bulges. Yeah.
Yeah. No, we'll change it. Needle दूसरी देना. Give me another one. So again, I'll try. This looks okay to me. This is okay.
Yeah.
Punctured?
Yeah, but you haven't punctured.
This is okay now?
Yeah.
The mid.
Punctured. We can see it now in the LA. We can see the coronary wire in the LA.
Yeah. We are punctured now. AP. No, AP. Okay. How is the position? Good? Okay. So now we can see that. So the puncture is successful. And you saw that we used the opposite end of this coronary wire, Dr. Dhal.
Yeah. I saw that. That was
so you can explain to them about this. Because we don't have the dedicated
needle.
Have
a Baylis and
so we do it this way. Yeah.
But most Indian labs and most Indian operators are pretty comfortable in puncturing the septum for PTMC. So, but this was pretty smart because at least
so we'll take the Agilis. So now the wire is in the LA. We are now going to take the Agilus sheet for the crossing. Correct. So these are the steps which we follow in every case. Okay. 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 So you can go to the view, RO cranial view, our working view. So please go to the working view. So here you see that we have taken the Agilus, and I'm going to now push this out slowly and put it in the water. So we need a water seal so that there is no air which is sucked in. Yeah, take it out. Take this whole thing out slowly, 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 slowly. Okay, out. Fine. Okay, good. You give me the flush. Okay.
You want to check the ACT now?
Yeah. So we can check the ACT, and now we are looking at the valve. So take a pigtail, please. Give me a pigtail. So this position looks reasonable to me, and we will do the cross it and then dilate it. Okay. So the steps will be the same all the time. Okay. So this is the pigtail. Hopefully it will cross
The Agilus is
smoothly.
positioned pretty well. And
Yeah, yeah.
should be.
नहीं नहीं मल्टी नहीं यही जाएगा.
So it's crossed very well. Now
Okay, so we are crossed, and now we will take a Confida wire. What we have? Safari. Safari. Balloon 14. So we are going to take a 14 balloon because this is a bigger valve, 26.
26.
Yeah,
Okay.
26. So for the septal dilatation, typically either we take a 12 or a 14. So we are going to take a 14 because sometimes we have seen, and we are going to use a Myval, which is the Indian balloon expandable valve. Okay, 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 okay. Okay, now we are fine. Okay, now we can
now the transition is smooth.
walk it out.
Yeah.
Walk out, कोई बात नहीं, ठीक है, निकाल लेंगे, तुम वो कर लो ना. हाँ, ये ठीक है, पोजीशन बिल्कुल ठीक है. Take it out. Take out the whole thing. Yeah. With the wire inside.
So what is your
Yeah,
wire
14.
choice for this? Normally, Praveen,
Yeah.
or what kind of wire do you prefer? A Lundquist or a Safari? What
I
is
think
it? that you-
Safari. This is a Safari. Generally, a small curve, ultra
curve
small curve
Safari,
Safari is okay.
Yeah. Doesn't get into the trabeculae.
Yeah, yeah, that's right. Yeah. So now we are ready to dilate the septum. So we'll take a 14 millimeter balloon. 14. Give us a 14 balloon. So at this stage, we have profiled the valve.
Yeah.
We have placed the wire. We are across the septum. We'll dilate the septum. And then in the meantime, you can also look at the images. How much is the gradient now, Manish? 15 by 25. And PA pressures? 55 is the PA pressures. Okay. And the patient has severe TR.
Yeah. So
Yeah. Okay. So hopefully we will be now ready. Can we have the balloon,
the
please?
balloon.
14. 14 का which one you have? Azmarda. Why can't we have the 14 that one, na? 12 दे दो. Give me a 12. कोई बात नहीं. So because the thing is that Mammoth balloon is a slightly higher profile
Higher
balloon.
profile. That's
Yeah, I will prefer this one first. Yeah. Give me this 12 millimeter balloon. And because this septum is a very fibrotic.
It is. We had
Yeah,
challenges even
yeah,
in the
yeah,
puncture, and
Yeah,
so
yeah.
want to be sure.
Yeah. Okay. So, and how much is the ACT? 400. That's okay. It's okay. Okay, fine. So we have given 5,000 heparin only, and we are fine. Okay. Ready? To the back. Okay. Is the valve ready? So you must check the orientation because the orientation of the valve has to be opposite. Okay. So you can see I am feeling some resistance here at the septum. So now we are across the septum. Go ahead. Go up. 1, 2. Deflate. Yeah. We have to go a little bit further. So in the meantime, are there any questions in the chat box? Dr. Dhal can take it. Okay, go up. 1, 2, 3, 4. Still there? 5, 6. It's okay. 7, 8, 9, 10. 10. Keep it at 10. 10. I think it's okay.
So
It's
I
a
think
good
you
size.
have a good septal dilatation.
Yeah. No. Keep it at 10. Yeah. So we have to maintain some, inflation so that the septum gets dilated well. Otherwise, we have seen sometimes, resistance in taking the valve inside. Okay. Deflate. Okay. So should we dilate with the 14 also? I think so.
Not relevant.
Take it out. Because I don't want any, issues at the time when we are crossing the valve. Yeah.
So there was a question in
the
the chat box which was largely related to aortic regurgitation. I just need to remind the viewers that what Dr. Praveen Chandra is doing right now is actually is doing a TMVR, valve in valve. It's a mitral valve here.
Or bring more. Yeah. Take. Okay. 14. So should we dilate with the 14? Yeah. Better. Because
So
we have seen in the past that if the valve is bigger, like sometimes we have used a 29 in mitral position, then it is extremely impossible to go with a 12 dilatation of the septum.
Dilatation, yeah.
And 26 is in between, so we should do the dilatation.
Yeah, but it's better to be safe.
And how is the RV functions in this patient? Not great. So we might have to even close it. Not really. Okay, go up.
We are across and
we are across. Yeah. 1, 2, 3, 4.
The indentation still there. And
5, 6. So we are dilating with a 14. Deflate. ठीक है. Okay, VT हो रहा है. मैं कर लूंगा. इसको निकाल लो. वायर थोड़ा सा पुश हो रही है ना. Okay. So we have done with 14. I'm Take it out. Take it out. Slowly.
yes,
Slowly. Yeah, done.
Out. Good.
So now we are ready. Yeah, we can take it out. So let's have the valve, please.
So this is the same valve. So, but we have to check the orientation because.
So in the meantime, Manish, can you explain? Is the puncture in the right position and how much? Yeah, it's in the mid, infero mid or infero posterior position, right? Mid.
It's a It's a good mid septal puncture because you can
So
see
here you can
in
see
the bicable view
the orientation that the the covered portion is here at the top compared to in aortic position where it is at the bottom. So covered portion at the top and the open portion at the tip. Okay. So we have to be very, very sure. Okay. So this is reverse to the aortic
the aortic deployment.
aortic deployment. Yeah. So this is the Myval 26 millimeter, and we are taking a 26 because of two reasons. One, this is a 27 millimeter perimount, which has an inner true ID of 25. So we can take either a 26 or a 27 and a half or a 29. But in this patient, because of the issue of
the new
LVOT, which was small, we are doing this. But on echo, we have seen that we can also get a reasonable idea sometimes. And we saw that probably it should be okay. So we'll go with a 26 although, and with 2 cc extra. Is it 2 cc extra?
2 cc, yeah.
2 cc extra. Okay. Okay. So here, this valve is a completely loaded valve, and we don't have a sheath or anything. So it should go, and now I will put it. So normally we put it like this. In this, we will do it reverse. Okay. So both all were okay. So the trajectory seems to be all right.
All right. Yeah.
Okay. I will bend it a little bit more. Yeah. So should be okay. Some problems here.
Cross September now.
Yeah. So we have crossed.
So we crossed them. Do you think you're going to, what are you going to do? 70, 30, 80, 20?
I think, we'll go by this, the annulus of the valve.
Yeah.
And yeah, I will now completely, this is straightened out completely. And I will push it a little bit more. And here we see that, in the sapien, it is recommended that, the middle marker should be just below just ventricular to the annulus plane. Yeah. Okay. So can we go to the same view? Is it okay? Center, please center this whole thing. Center, center, center. Okay. Okay. Can we just do a little bit more cranial? More cranial, more cranial. RAO, RAO. No. No. Go LAO, go LAO, LAO. Okay. Okay. I think we are fine now. Okay. So this position seems to be good to me. Okay. I go a little bit more, and that should be all right. Okay. Yeah. Yeah, I think it's okay. What do you say?
Yeah, I think it looks good. What about the echo? Can we get a ventricular view?
Yeah. It's okay?
Yeah.
On the 3D?
On the 3D. Yeah.
That will be better. So we are putting it a little bit towards the LVOT. Okay. I think we should be fine. Now it has gone a little bit inside. Now it has gone a little bit deeper, which I'm going to pull it back. Now,
Let's come back.
Keep a track on this. So this is some resistance because of the valve, which is stenotic. So sometimes it gives some resistance. Okay, so it moves a little bit faster. I'll go slowly back again. Maybe not. I think we are okay. I think we are fine.
Should be good.
Should be fine. Okay, little bit more proximal. So okay, I'll try and do that. Oh, okay.
Jump out.
It
Very
basically,
good position.
yeah, I think this should be okay. This is fine. Okay, so go to pacing 180. Slowly, Jana. 180. No, I'm not seeing any pacing happening.
We're not seeing pacing yet.
Hey, go to the pacing 180. There is no pacing.
Maybe the pacing lead. Yeah, now it's pacing.
Okay. Okay. Pacing is not happening properly. Can somebody check? Wobbling a lot.
Just push maybe the pacing lead a little bit.
But somebody has to. तुम इसको दबा के रखो. इसको ऐसे push करके रखो.
Now it's
हाँ. Okay. Go up. Slowly. हाँ. हाँ मैं pull कर रहा हूँ. हाँ. Gone up. Deflate. नहीं अभी नहीं. Deflate. ठीक है. Pacing off. Wire in.
just check.
Wire in. Yeah. Yeah. निकाल लो उसको. Check the PVL and everything. So we have deployed the valve. And did we expand fully? Not yet. Okay. Okay. So there is no PVL. And what about the gradients? I don't see any gradients also.
Oh, it's laminar flow. So
इसको निकाल लेते हैं क्या? निकाल लो इसको. आराम से. हाँ. So the valve has been deployed and we are taking the balloon out and we'll see. चलो निकाल लो. Okay.
so that's a central jet, Manish, or is it a paravalve jet? There's small PVL.
There is. So check the gradients.
So what kind of gradients do we accept in the LVOT before we want to do
I
a
think it should be
secondary
below.
alcohol separation?
But I think I will accept anything below 25. Should be okay. Can you check? So should we dilate more?
I think if you dilate more, you can probably get rid of that little PVL which we are having at the edge.
Yeah.
Yeah.
Not picking. Okay. So is it because of the wire? Because sometimes we see the gray, there's some leak from this through the valve because of the wire. Because of the wire. So if the wire is the cause, then we can take out the wire, put a pigtail and see how it is. Okay. Yeah, that we will see. First, you tell me this thing. Mitral
valve
yeah.
gradient.
Gradient and leaks.
I think that leak has come down.
It's hardly any.
Hardly any. And then
Yeah.
the flow certainly is laminar, so it's not turbulent. So that itself is a.
There is no gradient. So the mitral gradient is now how much? It is. So can you see the echo? Can you see the echo images? Focus on the echo images, please.
Yeah.
4 to 5. It's okay. 4. It's okay. Yeah. Earlier it was 15.
Yeah.
So
can
once the heart rate reduces,
PA
pressures. Yeah. So I'll change it with the pigtail now. Let's give a pigtail. So we'll take.
Could you expand the the valve fully, or do you want to go back again and do another millimeter or two?
The valve was inflated fully. So I think from that viewpoint, 33, which is very
Which
good.
is good. Okay, so even if it is 14, so we say it's still about 45.
So I'm with the pigtail inside. Okay. Okay. So give me a pressure line. Pressure line, please. नहीं वो लगी हुई है. One more. So there is no gradient. The LVOT, we are checking the left ventricular pressures and also the aortic pressures. There is no gradient. Yeah, so we can do one more dilatation there.
I think one more dilatation will
yeah.
be beneficial
That'll be nice.
because it's
yeah, it's from the both the side, little. So we will do that. Give me.
I think.
But the gradient is not there. So that part is over, I think. So if we check, we can check it again. Flush, please. Flush. We are going to check the gradients. Yeah. So this is the, this show me the LV, yeah, this pressure. 120, average is 120, 120, 128, some 120. So like average 120, okay? And here we have the aortic pressures. No gradient.
No gradient. So
There's
that's
no
fine.
gradient.
That means
So yeah,
the
this part
fears
is okay.
about the new LVOT is
not
really,
that much. Is not that much.
You were right, because the CT assessment was done at 75, which is more systolic. So therefore, it was causing more apprehensions.
Oh, sometimes this is like,
Yeah, this is like,
no, we have to now do the whole thing again. इसको बाहर निकालो. So we'll have to, if we have to take care of this thing, I'll cross it again. And I need a agilis again. Agilis. इसको निकाल लो. Wire should be in. But in exchange length wire, exchange length wire. वो दे दो ना, वो दूसरी ये implants wire. Pigtail is in the LA. And everything has improved. You see the systemic pressures have already improved quite a lot. And can somebody do the ACT again? We should keep checking the ACT. Okay. So take this out. Take this out. And give me the agilis. So we have seen, sometimes if you want to use this same safari wire, actually safari wire starts bending into the LA and then pulls the whole pigtail out.
okay.
So in those situations, better to curve a implants wire and then use that. Huh? Okay, 3, 2. Okay, so give me the pigtail then.
You could just have used a BMV round wire. And
Yeah. Give me the BMV jalebi wire. दे दो. So no problem. Sometimes you have to do 3 steps up or down. It's okay, but we have to finish this whole thing properly. So there is no panic, no hurry, no worry.
now the patient is also much more stable and
okay. So we are just going to do some more dilatation, and in the meantime, you can check about this septal defect, whether it is needs any closure.
You can
or
see the
just
RV. If the RV was rather dysfunctional, then we think we should not leave such a large septal defect. What is it that you take, Praveen, in your?
I mean, 90% time these days I don't close it because these defects, they shrink very quickly.
They do.
Yeah,
They do.
So this is this spring wire and goes into the LA. Yeah, check it out. So this will easily take the Agilis. Okay, go. Yeah.
Push the wire, please.
Okay.
Yeah.
Okay. 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 Push the wire. Push the wire.
Push the wire. Push the wire.
Okay. This is falling a little short, huh? Okay. Okay.
That was deft manipulation.
Just about. Just about. Yeah. So okay.
Perfect. You can curve it.
Hmm.
Yeah.
Slowly, slowly.
It's pointing well inside the mitral valve. And
Okay. 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 Flush, please. Flush. So give me a pigtail again.
obviously does not want any air embolization. So that's why this
Yeah.
detail to flushing repeatedly and ensuring that it's de-aired all the time.
And now we are going to do the post dilatation. So initially we thought that probably it may not need it, but now since we are seeing that it may need it, we'll do it. Okay.
Yeah, that's a better.
So give me the wire, please. Safari. So the best thing is that this gradient didn't show us here, and then we are happy. And now this post dilatation should do the final job.
Right, actually,
Yeah.
will further reduce the gradient and also reduce the paravalvular leak.
Yeah.
So that is.
जाने दो ठीक चलो निकाल लो वायर होल्ड द वायर balloon wire okay, so we are in position. Now we have to take this out also. Yeah Agilis Agilis out चलो और वायर होल्ड करो. Okay. Okay. Okay.
So are we crimped? Are we ready?
No, we don't have to. Just need the balloon.
Balloon. Are we ready?
Which size balloon is this? No, we could have used the same, or you can give this one. 26 is okay. Yeah, give me 26. Okay. So we'll take a 26 balloon and go ahead with this dilatation. Okay. So this was a 26 Myval, which we used actually 2 cc extra,
Yeah.
but now we are post dilating again with a 26 and see how it goes. Okay.
Have you put the 2cc extra this time, sir?
This time?
Yeah.
I don't think so. Holding? Hold karo. Ah. So it is inside. Okay.
Yeah.
So again, we have to start pacing when I tell you. Okay, Gina? Okay. And, but you have to be very forceful this time. Okay, pacing on 180. I mean, not now, not now. 180. ना अभी नहीं करना. इसको पकड़ लो. Hold this. हाँ, इसको दबा के रखो उस साइड. हाँ. Okay. Okay. Okay, go up.
He's had breakfast.
Deflate. हाँ. इसको निकाल लो. Balloon out. हाँ.
The PVL has decreased from what we can see initially.
Substantial reduction in PVL. Okay. Take it out. Call it. Bring it out. Bring it out. So tell
Interior
us,
side, there is-
any more dilatations? No, I think it's gone. There is no PVL now. Pigtail. Pigtail again.
वहाँ फोन करता हूँ रुको.
Pigtail.
Can we check the PA pressures?
PA pressures, you can check. You can check everything now. The gradients, we're just going to remove the wire now. Yeah. Take the wire out. Okay. Okay. Again, the wire is out. Yeah, so we'll take the pigtail out, wire, 014 wire. 014 wire. Yeah, we're going to take liya hai nahi.
So that's
Check
almost insignificant gradient. But four or five. looks
Not
like
even
the-
5, I think
yeah,
should
not
be.
even 5.
Yeah.
Mean gradient should be less than that.
So I have removed the pigtail from the.
Now we'll see. I think hopefully even that the central MR would have gone.
Yeah. AP.
That's it.
There is no MR now.
There's no MR now.
No MR. Okay. So
it's just a washing jet, which is,
yeah.
which is excellent.
Oh, yeah, I'm going to check that. No MR.
No MR.
So I think we are done. So
yeah,
we'll
I think we
remove
just
this.
Just review the LVOT once.
Yes. Review the LVOT and review the septal shunt left to right or what it is. It's left to right only. So it'll go away slowly. Yeah.
I think this should settle.
What do you say, doctor? She is 66. In another 10 years, she might require another one. So it's better not to close it.
Almost same 35, 36.
Okay.
Yeah, we'll check the LVOT now.
So LVOT we check, and if the LVOT is okay, then we are done. We'll close this through a figure of 8
Stitch.
suture. We need a thick suture, silk, which should not break because sometimes it breaks. No, but yeah, this is better. This is better. This is better. So shall we take this LA catheter out? And the echo, what do we see? Which is okay.
That's completely acceptable.
Yeah, it's okay. It's okay. Yeah, fine.
In any case, I think you can come out of the LA because you're not going to do anything more there. So
No, the only final
is that
question
whether
is
you want to close the hole. But you
no,
said,
I think we should leave it like that.
in a 65, 66
yeah, it's
year
better
old
not
lady,
to.
66-year-old lady,
Yeah,
we should probably leave it
yeah, leave
access
it.
for
We
the
will leave
future.
it. Yeah. So now you can focus on this so that we are going to remove this, and the figure of 8 stitch is going to come in. No pericardial effusion. And so I'm going to use the
And the appendage is clean.
double
Ligated, but whatever we can see is clean.
So this is seemingly a very heavy duty.
Yeah, it is because
It's a double suture. And just a minute. So I'm going to do this. This is a figure of 8. And Dr. Abhinav will take it out. Slowly. Okay, press it. So you can see that we avoided use of 2 proglides here, and typically we do this for all the patients, and it works quite well. There is no hematoma, there is nothing.
So when do you use a proglide in a venous, in a large venous axis?
Never. We don't do it. Okay. Slip kar raha, thoda pakad lo. Put some more stitches. It's okay.
So perfect. I think that was a lot of meticulous attention to detail, meticulous planning, and you got the size of the valve right. The choice of the hardware was perfect. You got a good transeptal puncture. Got very good access because there was a smooth transition across the septum into the prosthetic mitral valve, and absolutely went on tickety-boo. Perfect results. Congratulations.
Thank you. So I think we'll shift her back to the ICU, and maybe tomorrow we can extubate her.
Yeah.
And hopefully everything should be fine. Okay.
Great.
Thank you. Thank you very much.
A big round of applause.
And we will come back to you in 1 hour again with a coronary case. So thank you. Okay.